Imagine a patient, weeks, perhaps even months, plagued by this persistent nagging shoulder pain. It's it's not just discomfort, is it? It's this constant companion that really limits their daily life, impacts their sleep, prevents them doing even simple things they once took for granted. And for us clinicians, diagnosing and, well, effectively treating such complex chronic shoulder conditions can be incredibly challenging. The shoulder, with its intricate network of bones, tendons, ligaments, it's a marvel of human engineering, really, yet also incredibly vulnerable. Welcome to Deep Dive Ortho. Today, we're taking a really comprehensive look at shoulder arthroscopy, a procedure that has truly revolutionized orthopedic care over the last few decades. We'll delve into its fascinating evolution, explore its precise applications across a whole spectrum of conditions, and uncover the cutting edge advancements that are shaping its future, constantly pushing the boundaries of what's possible for patient recovery and outcomes. Now, this deep dive is for you, the discerning medical professional seeking to quickly yet thoroughly grasp the nuances of this critical surgical intervention. Our aim is to distill the most important insights, offer some surprising facts perhaps, and help you understand what truly matters in this rapidly advancing field. And to guide us through this intricate landscape, we have with us Prof. Mo Imam. It's a real privilege to have your insights today.
Thank you. It's a pleasure to be here and to unpack such an important area of orthopedic practice with you.
Okay, let's unpack this then. For those perhaps newer to the specifics, could you define shoulder arthroscopy for us? What does the name itself tell us, and why is this approach so transformative?
Absolutely. The term arthroscopy is, well, it's quite descriptive, actually. It stems directly from the Greek words arthro, meaning joint, and skopin, meaning to look. So as the name suggests, it literally means to look within the joint. In essence, it's a minimally invasive surgical technique that allows us, as orthopedic surgeons, to inspect, diagnose, and importantly, treat a wide array of pathologies inside a joint without the need for those large traditional open incisions. During a shoulder arthroscopy, we insert a very small camera, known as an arthroscope, directly into the shoulder joint. This camera then projects detailed magnified images onto a video monitor in the operating theater, which guides the surgeon as they manipulate miniature surgical instruments to perform the necessary repairs or procedures. That immediate high-definition visualization is really what sets it apart. The principal advantage, as you've hinted at, is undoubtedly the use of very small incisions, often referred to as keyhole incisions. This translates directly to significantly less pain for the patient post-operatively, a much shorter recovery period, and often a faster return to their daily activities compared to traditional open surgery, which, involved much larger dissections and more tissue disruption.
That emphasis on minimally invasive truly highlights a major shift in surgical practice, doesn't it? You mentioned its origins. How long has this technique actually been around for shoulder procedures, and how has it evolved to become such a cornerstone of modern orthopedics?
Well, shoulder arthroscopy itself has been performed since the 1970s. Its introduction marked a truly pivotal moment in orthopedics, making diagnosis, treatment, and patient recovery remarkably easier and faster than was once thought possible. Before arthroscopy, diagnosing complex internal shoulder issues often required an open incision, which meant a more invasive procedure just to see what was wrong, let alone fix it. So, quite a difference. Since those early days, it certainly hasn't been a static field, not at all. We've seen continuous improvements really each year, with new instruments, much better optical systems, and refined surgical techniques constantly being developed and integrated. Think of the progression from quite rudimentary scopes to today's high-definition cameras or the development of specialized suture anchors and repair instruments. This ongoing innovation is a powerful testament to its effectiveness and, I think, the unwavering commitment within the orthopedic community to continually refining patient outcomes. It's a technique that has truly come of age.
Before we delve deeper into specific procedures, let's just touch on the intricate anatomy of the shoulder. It really is a marvel of engineering, isn't it? Such a complex structure allowing for an incredible range of motion, often described as the most mobile joint in the human body.
Indeed, yes. The shoulder is arguably the most complex joint in the human body, precisely because it's capable of such an extraordinary range of motion, more so than any other joint. This incredible mobility, however, often comes at the expense of inherent stability, making it prone to various issues. It's not just one single articulation, but rather a complex of three bones working in concert. We have the humerus, which is the upper arm bone, the scapula, commonly known as the shoulder blade, and the clavicle or collarbone. Understanding these fundamental components and how they interact is absolutely crucial for any clinician, whether they're diagnosing a patient or performing surgery. Within this intricate structure, several key components facilitate its function, and importantly are often the sites of pathology we address with arthroscopy. First, there's the ball and socket configuration. The rounded head of the humerus articulates with a shallow rounded socket in the scapula called the glenoid. This entire surface, both the humeral head and the glenoid, is covered by a remarkably slippery tissue called articular cartilage. This cartilage ensures smooth, frictionless movement, allowing the bones to glide easily across each other, like perfectly lubricated bearings, really.
Smooth movement is key.
Absolutely. Then a critical structure encircling the glenoid is the labrum. This is a strong, fibrous cartilage that acts much like a gasket, effectively deepening the shallow glenoid socket, adding crucial stability and providing cushioning to the joint. Without a healthy labrum, the shoulder stability can be severely compromised, leading to issues like dislocations. Surrounding the entire joint, we have the shoulder capsule, formed by bands of tissue called ligaments that effectively hold the joint together. The inner lining of this capsule, the synovium, produces lubricating synovial fluid, which is vital for smooth joint function, much like oil in an engine.
Right, the lubricant.
Exactly. And central to the shoulder's dynamic stability and ability to move is the rotator cuff. This isn't a single muscle, but rather a group of 4 tendons that encircle the shoulder capsule, working synergistically to keep the arm bone perfectly centered in the shoulder socket during movement. This cuff covers the head of the humerus and attaches it to the scapula, facilitating powerful rotation and lifting motions. Lastly, we have the bursa, a lubricating sac strategically placed between the rotator cuff tendons and the bone on top of your shoulder, the acromion. The bursa's role is to facilitate smooth tendon glide, preventing friction and potential impingement, which can be incredibly painful. Understanding this detailed anatomy is paramount, as a significant number of indications for arthroscopy stem directly from pathologies affecting these very structures. Knowing these relationships guides our every move during an arthroscopic procedure.
So, with that robust anatomical foundation, which really highlights the shoulder's complexity, when would a clinician typically recommend shoulder arthroscopy? What types of painful conditions does it primarily address, and what's the decision-making process behind moving towards surgery?
Generally, shoulder arthroscopy is considered when a painful shoulder condition has not responded adequately to conservative, non-surgical treatments. These initial approaches are always prioritized and often include strict rest initially, a structured physical therapy program to restore movement and strength, and various medications or injections aimed at reducing inflammation. Inflammation, as you know, is the body's normal reaction to injury, and in an injured shoulder, it manifests as swelling, pain, stiffness. We truly emphasize exhausting these non-operative measures first, typically over a period of weeks to months, because actually a significant number of patients will improve without surgery. The decision to proceed with arthroscopy comes when the patient's symptoms persist despite a diligent and appropriate course of conservative management.
That makes sense, exhausting the conservative options first.
Precisely. In terms of common causes, most shoulder problems we encounter arise from direct traumatic injury, repetitive overuse common in sports or certain occupations, or simply the age-related wear and tear that tissues undergo over time. Arthroscopy is particularly effective in relieving symptoms from damage to key structures like the rotator cuff tendons, the labrum, the articular cartilage, and other soft tissues surrounding the joint. It's truly a versatile tool for precisely addressing the root cause of the pain and dysfunction.
That makes perfect clinical sense, exhausting conservative measures first, giving the body every chance to heal naturally. So once that decision point is reached and you're considering surgery, where does shoulder arthroscopy truly excel in addressing those persistent, debilitating conditions we discussed earlier? Could you elaborate on the specific conditions or procedures where arthroscopy is a primary choice, perhaps some of the most common ones you encounter?
Certainly. The indications for shoulder arthroscopy are quite widespread, reflecting its remarkable versatility and evolving capabilities. One of the most common primary indications we see is for rotator cuff tears. This involves repairing damage to that critical group of muscles and tendons that stabilize the shoulder, which, when torn, cause significant pain and restricted movement. Arthroscopy allows us to meticulously reattach the torn tendon to the bone, offering excellent functional restoration.
Right, that's a big one.
It is. Another crucial application is for labral tears. The labrum, as we discussed, that vital cartilage ring surrounding the glenoid socket, absolutely crucial for shoulder stability. Tears here can lead to instability or pain, and arthroscopy is essential for repairing this cartilage to restore normal joint mechanics. For individuals experiencing shoulder instability, characterized by recurrent dislocations or a persistent feeling of looseness in the joint, arthroscopic techniques can effectively address both acute and chronic issues by tightening the capsule or repairing the labrum, helping to stabilize the shoulder and prevent future dislocations. We also frequently use it for biceps tendon injuries. These often co-occur with rotator cuff tears, actually, but arthroscopy can specifically repair or release a damaged biceps tendon to alleviate pain and improve function, often through a tenodesis or tenotomy procedure. In cases of frozen shoulder or adhesive capsulitis, where there's significant stiffness and pain due to tightness in the shoulder capsule, arthroscopic release can meticulously free up the constricted tissues, allowing us to restore the patient's range of motion, often with dramatic improvements.
That must be a relief for those patients.
It really can be. Subacromial decompression is another common procedure. This involves arthroscopically removing bone spurs or inflamed tissue that contribute to shoulder pain during movement by impinging on the rotator cuff tendons, a very common cause of chronic shoulder pain. And of course, we use it for debridement and loose body removal, which basically entails clearing fragments of bone or cartilage from the joint that can cause mechanical pain, clicking, and impair joint function, often restoring smooth movement. Beyond these common indications, the technique is also expanding to less common but increasingly viable procedures such as nerve release for certain entrapment syndromes, certain types of fracture repair, cyst excision, and more complex indications including coracoaculavicular reconstructions and even certain Lauderjet and bone block procedures in select cases, truly pushing the boundaries of minimally invasive surgery.
That's quite a comprehensive list, showcasing the breadth of its application. Given its broad applicability and effectiveness, are there any situations where shoulder arthroscopy would not be recommended, or specific patient factors that would make it contraindicated, even relatively so?
Yes, absolutely. While shoulder arthroscopy is broadly applicable and generally safe, there are important contraindications that clinicians must be acutely aware of as they guide our decision-making and patient selection. An absolute contraindication would be an active infection, particularly if it's on the skin within the surgical field, or signs of systemic infection. Proceeding with surgery in the presence of an active infection significantly increases the risk of spreading that infection into the joint.
Which could be catastrophic.
Devastating, yes. It can lead to very difficult-to-treat consequences like septic arthritis. We simply will not operate if there's an active infection risk. There are also relative contraindications where we proceed with caution or additional measures. For instance, acne within the surgical field is considered a relative contraindication.
Really? Acne?
Yes, it might sound surprising, but this is because P. acnes, a common bacterium associated with acne, is a known pathogen that has been linked to shoulder infections following arthroscopy.
Gosh, that's a crucial insight.
It is. While not an absolute bar, it certainly raises a flag for increased vigilance and potentially requires specific preoperative skin preparation or perhaps a longer course of antibiotics. These considerations highlight the critical nature of comprehensive patient readiness and thorough medical evaluations prior to any surgical intervention. It's all about meticulously mitigating risks to ensure the best possible outcome for the patient.
Moving into the preparation phase then, which sounds incredibly thorough, what does patient readiness truly entail before undergoing shoulder arthroscopy? It sounds like it's far more than just a quick checkup.
Indeed, patient readiness is paramount for optimizing outcomes and is far more involved than a superficial checkup. It truly begins with ensuring the patient is in optimal overall health and well-being. This process typically involves a comprehensive clinical examination, which starts with standard X-rays to assess bone structure and often progresses to a magnetic resonance imaging, or MRI scan. The MRI is particularly valuable as it allows us to precisely define the nature and extent of the shoulder problem, giving us detailed insights into the soft tissues like tendons, ligaments, cartilage. This imaging helps confirm the diagnosis and guides our surgical plan. Crucially, as we discussed, we always emphasize that non-operative measures, such as a structured rehabilitation program or physical therapy, must have been thoroughly explored and exhausted before considering surgical intervention. This approach underscores our commitment to conservative treatment options as the first line of management, ensuring surgery is truly necessary and appropriately timed.
Beyond the physical checks and exhausting conservative measures, how important is it for patients to truly understand the surgical process itself, including what to expect post-operatively? It seems like managing expectations is absolutely key here, especially for something that clearly isn't a quick fix.
Oh, it's fundamentally important. Patients must grasp the surgical alternatives available, the potential risks associated with the procedure, and the expected benefits. This transparent discussion forms the absolute basis for setting realistic expectations regarding the outcomes. Patients must truly view shoulder surgery not as a one-off event that instantly fixes everything, but rather as a process that unfolds over many weeks and months. The ultimate success of the surgery heavily relies on their unwavering commitment to a comprehensive post-operative rehabilitation program.
So their active participation is vital.
It's a game changer. Without the dedicated engagement and adherence to the physical therapy plan, even the most technically perfect surgery may yield a suboptimal result. Furthermore, patients must anticipate and be prepared for a significant recovery period. Typically, individuals can expect to be less active for a substantial period, often ranging from 12 to 16 weeks post-surgery for significant repairs. This means daily activities that we often take for granted, such as driving, going shopping, or performing overhead tasks, can be significantly impacted. Therefore, planning for necessary assistance at home is essential, especially for those who are alone or lack readily available support networks. This foresight helps to minimize stress, prepare the home environment, and facilitates a smoother, less disruptive recovery journey. And what about the broader medical evaluations? Are there specific tests or discussions with other healthcare providers involved to ensure a patient is truly fit for surgery, particularly looking beyond just the shoulder itself?
Yes, absolutely. Prior to surgery, patients are very often referred to their primary care physician for a full medical pre-assessment. This evaluation is critical as it ensures any existing medical issues that could potentially affect their surgical experience, whether during the procedure itself or during the recovery phase, are identified and appropriately addressed. It might include a battery of tests, such as routine blood tests to check general health and clotting factors, an electrocardiogram to assess heart function, or a chest x-ray, all aimed at confirming the patient is medically well prepared and fit enough for the procedure, especially in terms of cardiac and respiratory health. If during this initial screening specific health risks are identified, perhaps a history of cardiac issues, uncontrolled diabetes, or respiratory conditions, then more extensive and specialized evaluations might be required, involving other consultants like cardiologists or anesthetists. And a very important aspect, one that we cannot overstate, is the medication review. We always encourage open and thorough communication with the orthopedic surgeon about all current medications, including over-the-counter drugs, herbal remedies, any supplements the patient is taking.
Because interactions can be serious.
Exactly. This is vital because adjustments may be necessary before the surgery, particularly for medications that affect blood clotting, like anticoagulants, or those that could interact adversely with anesthesia. This meticulous review helps us mitigate potential risks, such as excessive bleeding or adverse drug reactions during or after the procedure, ensuring the safest possible environment for the patient.
Fascinating how many layers there are to preoperative planning. Right, let's delve into the actual surgical approach now. What kind of anesthesia is typically used for shoulder arthroscopy, and what considerations guide that choice, given the nuances involved?
Well, most surgeons do prefer general anesthesia for shoulder arthroscopy. This ensures optimal pain control, complete muscle relaxation, and a still surgical feel throughout the entire procedure, which is crucial for the precision required in arthroscopic work. However, there are important considerations to be aware of, particularly with patient positioning. One potential drawback, especially when the patient is positioned in the beach chair position, can be a decreased mean arterial pressure due to the effect of gravity and the anesthetic agents.
Which carries risks.
Yes, it carries a rare but serious risk of cerebral hypoperfusion, which, in extremely rare cases, could lead to a devastating neurological event such as a stroke or even blindness. This is why careful monitoring of blood pressure and brain oxygenation, if available, is absolutely essential. Many surgeons, myself included, also choose to combine general anesthesia with a regional nerve block, most commonly an interscalene block, or even an indwelling nerve anesthetic catheter for prolonged pain relief. This regional block numbs the shoulder and arm, offering significant benefits. These include a substantially reduced need for narcotics during and immediately after surgery.
Which is a big plus these days.
A major advantage, yes, in managing post-operative pain and minimizing opioid exposure and their associated side effects like nausea and constipation. It provides excellent pain control for several hours post-procedure, greatly aiding the patient's initial comfort and facilitating early engagement with rehabilitation. However, it's very important for clinicians to be aware of the phrenic nerve being at risk with an interscalene block.
Ah, yes, the breathing nerve.
Precisely. It can cause temporary diaphragmatic weakness, leading to transient breathing problems or dysmorphia, particularly in patients with pre-existing respiratory conditions. It's always a risk-benefit assessment for each individual.
Once anesthesia is administered, how is the patient positioned for the surgery, and why are there different options for this? It seems like positioning alone carries significant, potentially life-altering considerations.
Patient positioning is indeed critical for achieving clear visualization of the joint structures, optimal surgical access, and, as you rightly point out, minimizing potential complications. There are two primary positions commonly used for shoulder arthroscopy, each with its own advantages and disadvantages. The first is the beach chair position. This is a semi-seated, reclined position, similar to how one might sit comfortably in a reclining chair. Its advantages are notable. It allows for relatively easy conversion to an open delta pectoral approach if, for any reason, an open procedure becomes necessary during the surgery. It also generally results in decreased venous pressure and bleeding within the joint, which significantly improves visibility for the surgeon.
Which is crucial in such a small space.
Absolutely, a crucial factor. However, it does come with disadvantages. Poor positioning and inadequate padding can lead to neuropraxia of various peripheral nerves, such as the supraorbital nerve, causing paresthesias or numbness over the forehead, the great auricular nerve leading to paresthesias over the ear, or the lateral femoral cutaneous nerve, resulting in paresthesias over the anterolateral thigh. Crucially, as I mentioned, it carries a higher risk of cerebral hypoperfusion compared to the lateral position, particularly if the neck is not positioned neutrally, which can unfortunately increase the risks of stroke or spinal cord ischemia. Meticulous attention to head and neck positioning is paramount here. The second position is the lateral decubitus position, where the patient lies on their side on the operating table. The primary advantage of this position is that it can facilitate joint distraction, meaning we can apply gentle traction to the arm to open up the joint space.
To get a better view, essentially.
Precisely. This can be particularly beneficial for certain types of repairs or when a greater working space is required within the joint, allowing for improved instrument maneuverability. However, similar to the beach chair position, it can also be associated with neuropraxias, sometimes due to the traction forces applied to the arm, potentially affecting their brachial plexus or ulnar nerve. The choice between these two positions often depends on the specific injury being treated, the surgeon's individual training, and their personal preference, as both positions offer distinct advantages and considerations, each demanding meticulous setup to avoid complications.
Fascinating how positioning alone carries such important considerations and potential risks. Could you walk us through the actual procedure, from initial preparation to closure, giving us a real sense of what happens inside that keyhole and how the surgeon navigates that intricate space?
Certainly. Once the patient is correctly positioned and the surgical area, primarily the shoulder, has been thoroughly prepped with an antiseptic solution to sterilize the skin, the surgical team typically places the patient's forearm in a specialized holding device. This ensures the arm remains perfectly still throughout the procedure, which is vital for the extreme precision required. The surgeon may then inject sterile fluid into the shoulder joint to inflate it slightly, a process known as distension. This inflation creates a clearer working space, allowing us to enhance the visualization of all the internal structures through the arthroscope.
Like inflating a balloon to see inside better.
Exactly that, yes, much like inflating a balloon to see its interior. Next, a small buttonhole-sized puncture, often referred to as a portal, is made in the shutter. This is usually the posterior portal, and it's where the arthroscope with its fiber optic camera is inserted. Fluid continuously flows through the arthroscope to maintain a clear view, washing away any debris or minor bleeding that might obscure our vision. The images captured by the arthroscope are immediately projected onto a high-definition video screen, allowing the surgeon to see the inside of the shoulder in exquisite detail and to precisely identify any internal damage or pathology. Once the problem is clearly identified, other miniature surgical instruments are inserted through separate, similarly small incisions or portals. These specialized tools are designed for incredibly precise actions within the joint. We have instruments for shaving away damaged or inflamed tissue, for cutting precisely, for grasping torn fragments, and critically for passing sutures and meticulously tying knots, all within a confined space. In many cases, particularly for rotator cuff repairs, where a tendon has pulled away from the bone, special devices called suture anchors are used. These are essentially tiny screws or coggles, often bioabsorbable, that are anchored directly into the bone, providing a secure reattachment point for torn tendons. The sutures are then passed through the tendon and tied or secured to these anchors, reopposing the tendon to its bony attachment site. After the necessary repairs or procedures are completed, the surgeon carefully closes the small incisions, typically with just 1 or 2 stitches or steri strips, and the area is then covered with a large, soft bandage for protection. It truly is a delicate dance of precision and coordination.
That detailed walkthrough really paints a picture. You mentioned these small buttonhole portals. Where are these precisely placed, and what are the crucial anatomical considerations to avoid nerve damage, given the shoulder's incredible complexity and the vital structures surrounding it? This feels like a moment where extreme precision is absolutely non-negotiable.
This raises an incredibly important question, yes. Precise portal placement is fundamental not only to technical success and access to pathology, but also to meticulously minimizing the risk of iatrogenic complications, especially nerve damage. We rely on a set of well-defined primary and secondary portals, each chosen based on the area of the shoulder we need to access and view. The posterior portal is typically the primary viewing portal used for diagnostic arthroscopy and for initial entry. It's usually located about 2 centimeters inferior and 1 centimeter medial, the posterolateral corner of the acromion. Clinicians must be acutely aware that this portal may pass between the infraspinatus and teres minor muscles, or directly through the infraspinatus. The axillary nerve is at significant risk if this portal is made too inferior.
So you need to be very careful with that depth.
Extremely careful. It runs approximately 7 centimeters below the acromion tip. Similarly, the suprascapular nerve is at risk if the portal is positioned too medially, closer to the scapular spine. The anterior portal is commonly used for viewing and for performing procedures like subacromial decompression. Its placement is lateral to the coracoid process and anterior to the acromioclavicular AC joint, and it passes between the pectoralis major and deltoid muscles. Here, the cephalic vein, which runs in the delta pectoral groove, is at risk if the portal is too lateral. More critically, the musculocutaneous nerve is at risk if the portal is made too inferior, as it enters muscles typically 2 to 8 centimeters distal to the coracoid tip.
Right, another critical nerve pathway there.
Indeed. The lateral portal is primarily used for subacromial decompression and often for suture passing and rotator cuff repairs. It's located 1 to 2 centimeters distal to the lateral edge of the acromion and passes directly through the deltoid muscle. Again, the axillary nerve is also at risk with this portal, given its course just deep to the deltoid. Beyond these primary portals, we have several secondary portals, which are typically placed under direct arthroscopic vision once we are already inside the joint, to ensure precise access to specific pathology and minimize blind insertions. Examples include the anteroinferior 5 o'clock portal for anterior labral repair, the posterior-inferior 7 o'clock portal for posterior labral repair, and the Nevisier supraspinatus portal used for anterior glenoid visualization and for certain superior labrum anterior posterior or SLAP repairs.
SLAP tears, yes.
Where the suprascapular nerve is once again a structure we must meticulously protect. There's also the port of Wilmington, posterolateral portal, useful for evaluating posterior SLAP and rotator cuff RTC lesions. It's also important to acknowledge that there can be significant anatomical variations, particularly in the region of the anterosuperior labrum and the middle glenohumeral ligament, MGHL, which is a key ligament stabilizing the joint. Sometimes what might appear to a less experienced eye as a labral tear is actually a normal anatomical variant where the labrum is congenitally absent in that area, often associated with a cord-like MGHL. This is known as a Buford complex.
Ah, so knowing your variations is critical.
Sure. Absolutely crucial to avoid misdiagnosis and unnecessary intervention. Furthermore, clinicians should be aware that bare areas of cartilage on the central glenoid and the posterior humeral head are normal anatomical findings and should not be mistakenly identified as pathology during diagnostic arthroscopy. As a crucial pearl for practice, needle localization prior to making any incision is extremely helpful in ensuring proper portal placement, maximizing access to the pathology while simultaneously avoiding iatrogenic damage. And a significant pitfall that can hinder the entire procedure is losing clear visualization due to bleeding within the joint, which is often caused by elevated blood pressure, underscoring the importance of meticulous hemodynamic control throughout the surgery. It truly is an exercise in applied anatomy.
That deep dive into portal placement truly highlights the exacting nature of shoulder arthroscopy. But the procedure itself is just one part of the equation, isn't it? The patient journey extends far beyond the operating theater. What happens immediately after surgery? And what's the typical recovery trajectory for patients on their path back to function?
Absolutely. The success of shoulder arthroscopy is, in fact, heavily dependent on diligent postoperative care and a fully committed, individualized rehabilitation program. Immediately after surgery, patients typically spend about 1 to 2 hours in the recovery room. During this time, nurses closely monitor their responsiveness as they emerge from the anesthesia, ensuring their vital signs are stable and provide appropriate pain medication as needed. Most patients are discharged home on the same day, which, as we discussed, is a key advantage of arthroscopic procedures over traditional open surgery. However, it is crucial that they leave with clear, comprehensive instructions on everything from incision care and trussing changes to prescribed exercises, activity restrictions, and the precise usage of pain medication. Critically, we always advise that someone needs to drive them home and, ideally, stay with them for at least the first night to provide support, assist with initial needs, and ensure their comfort and safety.
Pain management is clearly a crucial aspect of that immediate recovery. What are the common approaches to managing postoperative pain, and what are the important considerations for clinicians, especially regarding the use of stronger analgesics and making sure patients are comfortable without unnecessary risks?
Yes, pain and discomfort are certainly expected for several weeks, or even longer after more extensive repairs like a major rotator cuff reconstruction. Immediate application of ice is fundamental. It's a simple yet highly effective method for reducing both pain and swelling, which contribute significantly to discomfort. Regarding medication, options typically include oral pain medications such as opioids, nonsteroidal anti-inflammatory drugs, NSAIDs, and local anesthetics, which may have been administered as part of the regional block we discussed. Regarding opioids, while they can provide excellent pain relief in the short term, clinicians must be acutely aware of their significant risks, including the potential for dependence and addiction with prolonged use, as well as common side effects like nausea and constipation.
That's a major concern currently.
A huge concern. It is therefore vital to use them strictly as directed, for the shortest possible duration, and to taper them as the pain improves, often transitioning to NSAIDs or paracetamol. Education on this point for patients is critical to prevent prolonged or inappropriate use. Patients often find it more comfortable to sleep in a reclining chair or propped up in bed for the first few days after surgery, as lying flat can put uncomfortable pull or pressure on the healing shoulder. As for wound care, simple Band-Aids can replace the initial large bandage after a few days, and showering is usually permitted once the wounds are no longer draining, though we advise patients to avoid soaking or scrubbing the incisions directly to prevent irritation or infection.
And the sling, that familiar sight after shoulder surgery, how long is that typically required? And what vital role does it play in the early recovery phase, especially for those crucial initial weeks of healing?
Ah, yes, the sling. A sling or a special immobilizer is nearly always needed to protect the shoulder, particularly during the initial healing phase. The duration of its use varies significantly based on the specific repair that was performed. For instance, a simple debridement might require a sling for only a few days to a week, while a complex rotator cuff repair could necessitate continuous immobilization for 4 to 6 weeks, sometimes even longer, followed by a period of weaning. Its primary purpose is to completely immobilize the joint and the surrounding muscles, thereby reducing any unwanted strain or movement on the surgical site. This allows the delicate repaired tissues, like a reattached tendon, to heal securely and integrate with the bone without disruption from early motion.
Giving it the best chance to knit together properly.
Precisely. Patients can generally expect to gradually resume most daily activities that don't involve heavy lifting or overhead movement within 6 to 8 weeks. However, it's important to set realistic expectations that more physically demanding tasks, especially those involving the shoulder, may require a more extended period, often up to 6 months, for full recovery and unrestricted use. It's a marathon, not a sprint.
That makes perfect sense, giving the body time to properly heal. Rehabilitation is clearly a cornerstone of successful recovery, a long and dedicated process. Could you outline the general phases of a typical shoulder rehabilitation program and underscore why patient commitment to this program is so vitally important for achieving the best possible long-term outcomes?
Rehabilitation is, without a doubt, an absolutely essential part of the journey back to full function after shoulder arthroscopy. It's truly as critical as the surgery itself. The surgeon will develop a tailored, individualized plan for each patient, specifically based on the procedures that were performed and the patient's specific needs and goals. For more complicated repairs, a dedicated physical therapist often supervises the exercise program, guiding the patient through each meticulous stage and adapting it as progress is made.
That tailored approach sounds key.
It is. This rehabilitation follows a systematic, progressive approach, typically divided into distinct phases. The first 6 weeks post-surgery are primarily focused on pain reduction and allowing the initial tissue healing to occur. During this period, exercises are predominantly passive, meaning the therapist or the patient's other arm assists with movement, ensuring no active muscular strain is placed on the healing structures. This protects the repair. Then from approximately weeks 7 to 14, there's a gradual introduction of active movements and exercises. The goal here is to carefully improve the shoulder's range of motion, progressively increasing the load and complexity as healing allows and pain subsides. Finally, the weeks 15 to 22 phase, and often beyond, focuses heavily on strength-building exercises, neuromuscular control, and a progressive return to daily activities and more demanding tasks, including sports-specific or work-specific movements. It's crucial to impress upon patients that full recovery can indeed take up to 6 months, and in some complex cases even longer. It is inherently a slow, often challenging process that requires immense patience and perseverance.
It really demands that commitment from the patient.
Absolutely vital. Making a strong, consistent effort and diligently adhering to the surgeon's specific guidelines and the prescribed rehabilitation plan are absolutely vital for a successful outcome. Studies have clearly demonstrated that systematic rehabilitation, properly executed, can lead to significantly improved functional outcomes within the first 3 to 6 months, especially when compared to delayed or inconsistent rehabilitation protocols. The patient's commitment really is the game changer here. Their dedication to the exercises, even when it's difficult, directly translates into better functional recovery and long-term success.
While shoulder arthroscopy is widely considered safe and highly effective, as with any surgical procedure, there are potential complications and risks. What should clinicians and patients be aware of, even if these are generally rare, and how do we counsel patients on these?
It's absolutely crucial for both clinicians and patients to have a clear and comprehensive understanding of the potential risks, even though they are generally minor and, thankfully, treatable. We broadly categorize these into general surgical risks, which apply to almost any operation, and shoulder-specific complications. General surgical risks are those inherent to any operation and include things like allergic reactions to medications used during surgery, potential breathing problems or anesthetic complications, excessive bleeding, and the formation of blood clots, such as deep vein thrombosis. Specific to shoulder arthroscopy, while rare, patients may experience persistent shoulder stiffness post-operatively, sometimes evolving into a secondary frozen shoulder. Or, in some unfortunate cases, the surgery may fail to completely relieve their symptoms if the underlying pathology was more complex or if healing is incomplete. There's also the rare but potentially devastating complication of nerve injuries,
Which we discussed avoiding with portal placement.
precisely a key concern we constantly try to avoid through careful anatomical knowledge and technique. Re-tears of repaired tissues, particularly the rotator cuff, are also a risk, especially in larger tears or in patients with poor tissue quality.
Infection is always a significant concern in any surgical field, and you touched on P. acnes earlier. What are the rates for shoulder arthroscopy, and how might an infection present, particularly with some interesting nuances related to patient demographics or presentation?
Yes, infection remains one of the more serious complications we consider, though the overall rate for arthroscopic repairs is commendably low, typically less than 1%. This is largely due to the minimally invasive nature of the procedure and the stringent sterile techniques employed in modern operating theaters. However, it's worth noting that rates can be slightly higher for more invasive shoulder surgeries, such as shoulder arthroplasties or joint replacements, simply due to the larger exposure and implanted materials. Now, regarding that nuance, an interesting clinical observation, particularly relevant for arthroscopy, is that an infection might manifest quite subtly. It sometimes presents as a postoperative frozen shoulder that simply doesn't respond to standard treatments, or an unexpected persistence of pain and stiffness rather than overt pus or redness initially.
So it can be insidious.
It can be, yes. And this is a surprising insight for many, but it has been noted in some reviews that infection rates could be potentially higher in younger, sporty males with acne. This suggests P. acnes, that common bacterium associated with acne, as a relevant pathogen in this context, underscoring the importance of meticulous skin preparation. It's vital that patients are educated to recognize signs such as increased pain that doesn't respond to medication, escalating swelling, warmth, redness, pus draining from the incision sites, or a persistent fever. Any of these necessitate immediate communication with their healthcare providers for prompt evaluation and management, as early intervention is absolutely key.
Those insights into infection presentation are truly valuable. You also mentioned specific complications related to different procedures, like stabilization versus replacement. Could you elaborate on those and what current outcome reporting tells us about surgical effectiveness and complication rates across these different interventions?
Indeed, the outcomes and specific risks can vary depending on the precise procedure performed, and this is crucial for managing patient expectations. For arthroscopic shoulder stabilization, undertaken for instability due to recurrent dislocations, there is a risk of recurrent dislocation or instability post-surgery. This risk can range quite widely, from 5% to as high as 40%.
That's quite a range.
It is, and it's particularly noted to be higher in younger, very active males, especially those involved in contact sports, or those with specific injury patterns, such as significant bone loss from the glenoid or humeral head after multiple dislocations. This is a key discussion point with these patients. The Latarjet procedure, which is an open bone block procedure sometimes used for more severe instability with significant bone loss, generally has a lower dislocation risk, approximately 2% to 5%, offering a more robust mechanical block. However, it does carry slightly higher risks of infection and stiffness compared to a purely arthroscopic stabilization, highlighting the trade-offs between different surgical approaches.
So, higher stability, but potentially other issues.
Exactly that sort of trade-off. For shoulder replacement, or arthroplasty, while it's a different scale of surgery focused on joint resurfacing for arthritis, there is a distinct risk of the prosthetic components loosening without infection over time. This may necessitate further revision surgery down the line. The estimated risk for this occurrence is about 1 in 20 over an 8-year period, which is an important statistic to discuss with patients considering joint replacement as a long-term solution. In terms of outcome reporting, recent comprehensive reviews, such as those conducted by Dr. Lohr, have provided valuable insights into the real-world effectiveness of shoulder arthroscopy. His reports indicate overall complication rates of around 8.3%, with a reoperation rate of 4.1% in a significant cohort of 241 patients undergoing various shoulder procedures. This kind of transparent outcome measurement is incredibly important. It underscores the ongoing need for rigorous evaluation of surgical effectiveness, allows us to continuously refine our practices, identify areas for improvement, and fine-tune patient selection criteria. It's about being accountable and striving for continuous improvement in patient care, ensuring we are delivering the best possible results.
This brings us to where it gets truly exciting. How have recent advancements in technology and surgical techniques pushed the boundaries of shoulder arthroscopy, leading to even more precise interventions and significantly improved outcomes for our patients? What's really on the cutting edge now?
Well, the field of shoulder arthroscopy is incredibly dynamic, and we are witnessing significant advancements that are continuously improving both the precision and overall effectiveness of the procedures. In terms of technological innovations, the introduction of bioabsorbable suture anchors has been nothing short of a revolution, really. Initially, these anchors are made of metal, but now they are predominantly bioabsorbable. This offers distinct advantages, such as providing higher pull-out strength, particularly valuable in patients with poorer quality bone, like those with osteoporosis. The materials used, like polyl-lactic acid, PLLA, and aromatic calcium phosphate, STCP, are designed not just to hold the tendon in place temporarily, but to actually enhance osteoconductivity and promote early bone formation as they gradually dissolve over time, essentially being replaced by the patient's own bone.
So they encourage natural healing.
Precisely. Other materials like polyether ether ketone, PEEK, provide excellent stability and biocompatibility without being absorbed, offering surgeons a wider range of options depending on the specific biomechanical needs of the repair.
Yeah.
Additionally, techniques like knotless double-row repairs, utilizing fully threaded anchors, have significantly advanced rotator cuff repair. These techniques allow for extremely secure fixation with a minimal profile, and crucially, they increase the tendon-to-bone contact area. This expanded contact area is vital for optimizing biological healing, as it maximizes the surface over which new blood vessels and healing cells can bridge the gap, leading to stronger and more reliable tendon reattachment.
That makes biological sense.
It does. Moving to surgical technique evolution, we are seeing a broadening of indications for arthroscopy due to these ongoing, minimally invasive advancements. Innovations like bioinductive scaffolds, which are essentially biological patches combined with advanced arthroscopic delivery methods, are showing immense promise. These scaffolds are designed to enhance the healing potential of rotator cuff tears, particularly larger, more complex ones. Studies have already demonstrated improved healing rates and structural integrity when these are used compared to traditional debridement methods alone, by providing a matrix that encourages cellular ingrowth and tissue regeneration.
Like giving the body a helping hand.
Exactly. Looking further ahead, while still in early stages for shoulder arthroscopy, robotic-assisted techniques are anticipated to develop significantly. This area holds the potential to offer even greater precision, tremor elimination, and efficiency, mirroring the advancements we've seen in other surgical specialties, potentially allowing for even more complex procedures through smaller incisions.
Beyond the surgical advancements themselves, what about biologics and their role in enhancing healing? And what do we know about how professional athletes, who inherently put their bodies through extreme demands, fare after these complex procedures? Their return to elite performance must offer unique insights.
Yes, the exploration of biologics is indeed a frontier holding immense promise for orthopedic surgery, moving beyond just mechanical repair to truly enhance biological healing. Research into treatments like platelet-rich plasma, or PRP, derived from the patient's own blood, and other growth factor therapies is robust and ongoing. The primary aim of these biological adjuncts is to enhance tendon healing post-surgery, particularly addressing the persistent challenge of non-healing or re-tears in certain rotator cuff repairs. By introducing concentrated healing factors, we aim to improve overall success rates and patient outcomes, fostering a stronger biological environment for repair. It's a fascinating area as we look to harness the body's own healing capabilities more effectively. A truly fascinating area of study is how these procedures impact professional athletes, who inherently push the boundaries of human performance and serve as a high-stakes test case for recovery. A comprehensive review of athletes from major leagues like the NFL, NBA, MLB, and NHL showed an overall modest return to play, or RTP, rate of 80.3% after shoulder arthroscopy. However, the real insights lie in the sport-specific differences, which highlight the unique biomechanical demands of each activity.
So it really depends on the sport.
Very much so. MLB players, particularly pitchers and overhead throwers, had a significantly lower RTP rate compared to other sports. They also had the longest average time to RTP, a remarkable 413 days, and the shortest post-injury careers. This, to me, underscores the immense repetitive stress placed on the shoulder during the throwing motion. Despite these challenges, what's intriguing is that once they did return, they showed no significant performance decline. This tells us the surgery was effective, but the path back is arduous and demands extreme dedication.
Quite a specific challenge for baseball players, then.
It seems so. Conversely, NBA players had the shortest average RTP time at 201 days and the longest post-injury careers. Both NBA and NHL athletes experienced a temporary decrease in performance in their first post-operative season, which is understandable given the recovery and adaptation period, but they often returned to or even improved upon their pre-injury levels by season 2, demonstrating remarkable resilience and the success of dedicated rehabilitation tailored to the sport's demands. It really shows how individualized recovery paths are, even within elite athletes. And connecting back to our earlier discussion on anesthesia for pain management in these outcomes, studies comparing a suprascapular nerve block combined with an axillary nerve block, SSMB plus A and B, against an interscaling block, ISB, for shoulder arthroscopy, have shown SSMB plus A and B to be more effective for pain relief and patient satisfaction within the first 24 hours. Yes, and notably, it also significantly reduces the incidence of dyspnoea, or breathing difficulty, compared to an ISB, an important safety consideration that can improve early patient comfort and reduce anxiety during the immediate postoperative period. These are the kinds of nuanced details that significantly impact the patient experience.
This raises an important question, though. Considering this rapid pace of innovation and the quite nuanced outcomes across different patient populations, from everyday individuals to elite athletes, how do we best balance the benefits of these advanced techniques with the inherent complexities and specific needs for each individual patient? It seems like precision in patient selection and counseling is becoming as crucial as surgical precision itself. What a truly insightful deep dive into shoulder arthroscopy. From its historical roots and that intricate anatomy to the latest surgical techniques, the nuances of rehabilitation protocols, and even the compelling performance trajectories of elite athletes post-procedure. We've covered so much ground today.
It's been a privilege discussing these critical aspects. The ongoing evolution of shoulder arthroscopy truly continues to enhance our diagnostic capabilities and expand our treatment options, consistently offering improved outcomes for our patients. The journey of continuous learning and refinement in this field is endless, really, and it's a constant drive towards better, more individualized care.
Indeed. And for you, our dedicated listener, we hope this conversation has offered valuable perspectives, sharpened your understanding, and perhaps provided those aha moments you seek. If you found this discussion valuable, please do consider rating and sharing Deep Dive Orso with your colleagues. It truly helps us bring more insightful discussions like this to you. So, as we look to the future, how might the increasing adoption of real-time intraoperative imaging, perhaps even augmented reality overlays, and sophisticated artificial intelligence refine our surgical decision-making and further personalize rehabilitation pathways in shoulder arthroscopy? What more could we potentially unlock for our patients when we move beyond even our current impressive capabilities?